This is an early phase 1 study, dose escalation for feasibility of this product. And so the genesis of this idea was the acknowledgement that many types of bone marrow failure syndromes, particularly aplastic anemia and myelofibrosis, involve a highly immunogenic and inflammatory bone marrow microenvironment. In the case of aplastic anemia, we know that there are auto-directed cytotoxic T cells that lead to significant bone marrow suppression, often by direct killing of the bone marrow stem and progenitor cells. Similarly, in myelofibrosis, we know that there is an inflammatory environment potentially mediated by dysregulation of the JAK-STAT signaling pathway. And so the idea was that, and we also know that in these same microenvironments, that there is a lack or almost an exclusion of Tregs. And so there's a significant deficiency of Tregs or regulatory T cells in that microenvironment. And so the idea was that in these patients who have a bone marrow failure syndrome related to either aplastic anemia, myelofibrosis, or other inflammatory condition, could we potentially introduce Tregs to counteract some of that auto-directed T cell activity and improve hematopoiesis, therefore reverse bone marrow failure? And these Tregs are derived from cord blood that's taken from a cord blood bank. And the Tregs have been used previously in studies of graft versus host disease, and we knew that they were safe, and we wanted to see if they were effective in this setting. And the idea was that Tregs can act on the bone marrow and the inflammatory microenvironment in multiple different ways. They can act directly on the cytotoxic T cells with lytic and cell death, with granzyme B, et cetera. They can secrete inhibitory cytokines to try to soothe or calm down the cytotoxic T cells, but certainly they can migrate to those sites and lead to a reduction in inflammation and improvement in hematopoiesis. In a mouse model of bone marrow aplasia, in a xenogenic mouse model, injection of cord blood T cells, Tregs, actually led to recovery of bone marrow cellularity and recapitulation of hematopoiesis. And so we felt that we had pretty good rationale to consider this in patients with bone marrow failure who had already been treated with their frontline primary effective therapy and had not responded adequately. And so the way this trial was designed, it was a dose escalation trial of the number of cord blood-derived T regulatory cells. There were 3 dose levels, starting with 1 × 10⁶ cells per kilogram. Next dose level, 3 × 10⁶ per kilogram, and finally 1 × 10⁷ per kilogram. In patients with aplastic anemia, MDS, hypoplastic MDS, or low-risk MDS, as well as primary myelofibrosis who had received initial frontline therapy without response were eligible. Patients were identified, HLA typing was done, and once the HLA information was available, a specific cord blood unit that matched at least 3 out of 6 with the donor, with the recipient, were selected, sent to the manufacturer, sent to the sponsor. The Tregs were then manufactured, expanded, and the infusion bag was sent back about 2 to 3 weeks after the initial cord blood was selected, and the Tregs were infusion. It was only a single infusion per patient. Again, safety, feasibility were the primary endpoints. We have enrolled 6 patients thus far. We have 4 with primary myelofibrosis who had failed or who were not responding to ongoing therapy, and 2 patients with aplastic anemia who had both received combination immunosuppressive therapy with ATG cyclosporin and L-trombopag. And what we saw was very interesting. First and foremost, there was no safety signal. Patients tolerated all the infusions well. There were no early or late toxicities attributed to the infusion itself. In fact, most people said that they felt no different. And interestingly enough, in patients with myelofibrosis who had significant symptoms, including B symptoms, pain, fatigue, in the weeks following the infusion, they said that they felt better with an improvement in their symptom score. In one patient, the JAK2 mutant allele burden dropped transiently from 86% down to 49%. In both patients with aplastic anemia who had already received ATG cyclosporin and were continuing on cyclosporin beyond 6 months and still were transfusion dependent, had a reduced transfusion frequency, one of which actually became transfusion independent while or after receiving the Treg cells. And so, again, the safety profile was excellent. The study is still early. 3 more patients are being enrolled currently at the highest dose level. And we hope to eventually confirm the safety and then investigate multiple dosing in patients to see if we are seeing concrete and durable improvements in bone marrow recovery.